Medurstand-Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today we are going to talk about this very common condition, cirrhosis of liver, or simply cirrhosis. When we call cirrhosis, it obviously means cirrhosis of liver, and it is often called chronic liver disease also. But I believe chronic liver disease is little ambiguous term because there are many chronic diseases of the liver which do not fall under the heading of cirrhosis. So I think it is best to call it cirrhosis. But in the literature, we often use this word chronic liver disease or simply CLD. So let's get started. In today's lecture, we will just cover the basic outline of chronic liver disease because it is a fairly big topic. Many dimensions like portal hypertension, hepatic encephalopathy, hepatocellular carcinoma, ascites, spontaneous bacterial peritonitis, all these will be covered in separate videos. So in today's lecture, I'm going to give you an outline. So terminology, I've already explained cirrhosis of liver or cirrhosis or chronic liver disease. And when we call cirrhosis, we could be talking about two varieties or two stages. One is compensated. That means pathologically speaking, patient has cirrhosis, but it does not have all those classical features which come when we have decompensation. There is no definite decompensation, but I think anybody who has cirrhosis with either splenomegaly or ascites or history of encephalopathy or jaundice, they will be classified as decompensated cases of chronic liver disease. Now, what is it? Very basic definition. Chronic liver disease is characterized by diffuse degeneration. And diffuse means that it affects the entire liver. Cirrhosis of liver does not affect one lobe or one part of the liver. It is usually the entire liver. Although the involvement is patchy, diffuse degeneration, that is the primary problem because of some insult, alcohol or some drugs or some metabolic disease. There is injury to the hepatocytes that leads to degeneration and necrosis, which is followed by regeneration. Now, liver has got a unique capability of regenerating itself. So there are areas of degeneration interspersed with areas of regenerations, and there is progressive fibrosis. In fact, this fibrosis makes it cirrhosis because fibrosis is the same as cirrhosis, and that results in two major problems. One is portal hypertension, and I'll explain it in some other slide in detail, because portal blood has to pass through the liver and only then it get to the heart and then into the circulation. If there is cirrhosis of the liver, there is mechanical obstruction of the flow and the blood cannot flow easily through the liver, and it then develops into portal hypertension and other problems. And then there is progressive liver failure. There are many manifestations because of the liver cells are not functioning properly. Let me explain to you one thing. For very long period, maybe up to a decade or so, patient will have cirrhosis, but it is well compensated. Patient may have some compromised functioning, physical, mental, sexual, but no gross manifestation. So patient may be living a reasonable life. Only when it goes beyond a certain point, then it causes this portal hypertension related problems and hepatocellular dysfunction related problem. So this is the gross pathology. If you look at the liver, this would be the appearance, and this is, I think, the macronodular. There are two varieties, micronodular and macronodular. If these nodules are bigger than 3 mm, it is classified as macronodular. So the commonest variety of cirrhosis which we see due to chronic hepatitis and due to alcohol is micronodular. So this is the histology. Of course, that is not my subject, going into the details of histology, but there are areas of regeneration, there are areas of fibrosis, and overall architecture of the liver is changed so that there is hepatocellular dysfunction and fibrosis due to leading to portal hypertension. So etiology, the commonest etiology is or used to be chronic hepatitis C, at least in our country. Hepatitis C was rampant, and I have a separate video on hepatitis C, and you can refer to that video if you are interested. Chronic hepatitis C was very rampant and there was no effective treatment. Luckily now we have a very effective treatment of hepatitis C, and the incidence of hepatitis C related cirrhosis is definitely declining. Then chronic hepatitis B. Hepatitis B was also once as common as hepatitis C, but it became less common because of the advent of vaccination. And these days we have effective treatment, although we have to continue that treatment for almost lifelong period, but we have effective treatment of hepatitis B. So hepatitis B related chronic liver disease is also declining. Alcoholic hepatitis, this is very well-known condition. Just normal or social drinking usually does not cause any problem, but those who drink excessively alcohol abuse, they are likely to develop progressive liver damage followed by cirrhosis. So that is common. In the West at least, in our country, we do not know exactly the prevalence of drinking and prevalence of alcohol-related chronic liver disease. And there could be a coincidence. Somebody with infection with hepatitis C and B may be drinking alcohol also. So in that case, it will be difficult to decide if the liver damage is due to alcohol or hepatitis C. In any case, if somebody has chronic liver disease, alcohol should be completely stopped, because even social drinking can add to the damage. Then this condition, I think this is a very important condition. This is becoming more and more common. Non-alcoholic steatohepatitis. There is a separate video or going to be one on this. This is actually the metabolic syndrome or fatty liver. Fatty liver appears to be a benign condition, but actually it is not. It could lead to non-alcoholic steatohepatitis when there is elevation of ALT and then followed by cirrhosis. And because of our increasing weight and because of our limited physical activity, the incidence of non-alcoholic steatohepatitis and related cirrhosis is increasing. And this is actually becoming the #1 indication for liver transplant. Autoimmune hepatitis, I'm not sure how common it is. It's certainly not as common as other conditions listed above, but autoimmune hepatitis also exists, and that could also lead to CLD. Then cryptogenic CLD. And cryptogenic is something we cannot determine the etiology. Now, we still see people who have developed cirrhosis. They don't fall into any of these groups. Maybe they had viral infection and that viral infection is now not there, but it has caused damage, or it may be some unknown etiology. But there are people where you would see cases of the CLD, chronic liver disease or cirrhosis, but will not be able to pinpoint the etiology. So natural history, different conditions have different natural history, but taking the example of chronic hepatitis C, which is I think the prototype, most patients will not develop cirrhosis, at least in the first few years. Only 20% of people who are infected with chronic hepatitis C virus will develop cirrhosis in approximately 20 years. So the remaining 80% will remain in the state of chronic hepatitis or will get cured because of the treatment or natural recovery. But only 20% will develop cirrhosis. We have seen those who develop cirrhosis, that is usually progressive. It may progress at variable pace, but it does progress. So ultimately it becomes cirrhosis, that is chronic liver disease. And then also some of these patients will go on to develop hepatocellular carcinoma. This is the example of chronic hepatitis C. typically first chronic liver disease and then hepatocellular carcinoma. But if this is a case of hepatitis B infection, people may not develop chronic liver disease, they straight away may develop hepatocellular carcinoma. And then finally, it would progress to what we call decompensated chronic liver disease. And this is a patient who has history of encephalopathies, the patient who has hypoalbuminemia, the patient who has got splenomegaly, ascites, and GA bleeding due to varices. So this is the typical decompensated chronic liver disease. These patients, they have a lot of morbidity and mortality. So we I think focus on this one. Of course, our aim is to prevent this thing from happening, but most patients, when they come to us, they come with DCLD and we have to manage them. Okay, the pathophysiology, I think it is broadly classified or categorized into two groups. The first one is portal hypertension. Now let me explain this in some more detail. All the blood from the intestine and the stomach, after absorbing nutrient and also taking up the toxins, it is brought to the liver. There are different branches and then it becomes one portal vein and it is brought to the liver. And then in the liver it turns into sinusoids and then ultimately hepatic vein, and the hepatic vein drains into the inferior vena cava, then ultimately to the right heart. So whenever there is obstruction here, this blood, the portal blood, will not easily pass through the liver. It will, of course, some part, but the pressure will start building up. Now once pressure in the portal vein starts building up, the portal vein will dilate, and it's all branches coming from the spleen that would dilate, and all the veins will dilate. But one manifestation of this portal hypertension is these potential anastomosis between portal system and the systemic circulation in the lower part of the esophagus. They would start dilating. Now this is nature's protective mechanism. This pressure, which is this blood, the portal blood, which is not going anywhere, find an alternate route, and then from here it goes to the heart and onward to the circulation. But there are two problems. One problem is that when too much blood passes through these veins, they start dilating and then they can sometimes rupture. This is varices. The second problem is the blood which was supposed to pass through the liver and toxins were to be removed and nutrients were to be absorbed, it bypasses liver and goes to the systemic circulation, and that also causes problem. So there is an immediate solution by the nature provided by these varices, but it can lead to certain complication, that is upper GA bleeding and precipitation of hepatic encephalopathy. There are many other areas where these varices are present, maybe in the splenic hilum and also in the rectum, but most important is the esophagus. And this pressure, the portal pressure, once this pressure goes back into the capillaries, there will be more oozing of fluid into the peritoneum, or less fluid from the peritoneum will be absorbed. So that will lead to accumulation of fluid in the peritoneum, and that will lead to ascites. Similarly, this portal pressure will lead to distension of the splenic sinusoid, and spleen will enlarge, and this will cause splenomegaly. So due to portal hypertension, you can explain all these clinical features. So that is the one component. And the second one is hepatocellular failure. You know, when liver cells are dying, others are regenerating. So for very long period, patient does not have any manifestation due to hepatocellular failure. But ultimately, the total functional liver cell mass is reduced, and then patient develops various issues. And I have given you the example of hepatic encephalopathy. That means all those, liver has got two types of function. One is excretory. Many toxins are excreted from the body. The other is synthetic. So when liver cells are damaged, both will happen. When synthetic liver functions are compromised, then albumin will be reduced. So hypoalbuminemia with associated issue will occur. When excretory functions are affected, then this ammonia will not be excreted. Ammonia will not be converted into urea and will not be excreted. There are many other metabolites which will accumulate, but I'll just take the example of ammonia. It may lead to hepatic encephalopathy and jaundice and hyperbilirubinemia, and this has got effect on the neurons. So these two examples, basic aim is to say that patient with chronic liver disease would have two types of manifestation, those which can be explained on the basis of portal hypertension and those which can be explained on the basis of compromised synthetic and excretive function of hepatocytes. Now let me now give you some examples. Portal hypertension related manifestation, there may be splenomegaly, but remember in patient with cirrhosis there may be a lot of ascites, and even if spleen is palpable, even if spleen is enlarged, you may not be able to palpate it. There is a special method of palpating spleen. If not palpable, it should be detectable on ultrasound. Then ascites, accumulation of fluid in the peritoneum. There are actually multiple mechanisms contributing to this ascites, but I think most important is portal hypertension. Other contributing factors are hypoalbuminemia and hyperaldosteronism and elevated level of antidiuretic hormones. All these, they contribute to accumulation of fluid, and that is called ascites. And I will have a separate video on ascites then. Occasionally, there may be superadded bacterial infection. This is called spontaneous bacterial peritonitis. So this can be a complication of ascites. Then varices. Varices may be asymptomatic initially, but later on one of them may rupture, then that could lead to massive GA bleeding. Upper GA bleeding or lower GA bleeding. There will be a separate video on that also. So these are portal hypertension related manifestation, and then hepatocellular function related manifestation, jaundice. And you may be surprised that jaundice is not exactly very common in patients with cirrhosis. Although the liver is damaged, but there is still fairly large number of functioning hepatocytes. So jaundice would be seen only in extreme cases. Either somebody has got very advanced cirrhosis or patient who has acute on chronic liver disease. They would have jaundice. Most other patients would not have jaundice. Bilirubin may be elevated by maybe a few decimals. So against 1 milligram upper normal, it may be 1.2, 3, 4 like that. Only occasionally it would be sufficiently elevated to cause jaundice. Hepatic encephalopathy. Hepatic encephalopathy occurs because liver cannot excrete potentially toxic substances which can act as false neurotransmitters. And these false neurotransmitters, they have predominantly inhibitory action on the neurons. So patient may become drowsy and patient may develop various manifestations of hepatic encephalopathy like tremor, like altered speech, like sleeping pattern alteration. So all these things will happen if there is hepatic encephalopathy. Patient with chronic liver disease may have mild degree of hepatic encephalopathy, and that will be difficult to identify. So I think be vigilant to identify milder degrees of hepatic encephalopathy. Then hypoproteinemia, if somebody with low protein, because albumin is synthesized by the liver and albumin may be reduced. Once albumin is reduced, there may be, it would contribute into ascites, but it may also cause generalized edema, like pedal edema, like scrotal edema, like presence of fluid in the pleural cavity and facial edema. So all these things are caused by hypoproteinemia. Hypoalbuminemia. Coagulopathy, clotting factors are also synthesized by the liver. Most importantly, prothrombin. So prothrombin level may be reduced and patient may have coagulopathy. In fact, portal hypertension may be responsible for bleeding, but background coagulopathy also contribute. Normally, whenever there is a bleeding from wherever, this normal clotting factors, they try to stop it and try to seal the bleeding point, but because of the background coagulopathy, these people with chronic liver disease, they tend to bleed profusely, and they may have bruises also. Whenever they have cut, they are likely to have more profuse bleeding. Gynecomastia, because hormones are also affected. In men it may cause gynecomastia or testicular atrophy, and in women it may also cause infertility and menstrual problems. And then spider angiomas. Spider angioma is also one of the manifestations. We do not know exactly the mechanism how these spider angiomas are made, but these are dilated capillaries. You can see this is a very vivid picture of spider angioma. Everybody with chronic liver disease, cirrhosis, they do not have spider angiomas. But if you suspect chronic liver disease, then I think you should examine the skin very carefully, front and back, particularly the upper part. The upper part of the body, you need to examine very carefully and to identify these spider angiomas. They're called spider because they look like spider, and angiomas because they consist of dilated vessels. Then you may also have gynecomastia. Of course, there are other causes of gynecomastia, but if there is background liver disease, then you can see the enlargement of the breast tissue, one-sided or both sides, and this would be called gynecomastia. Then ascites, of course, is the major manifestation of chronic liver disease or cirrhosis, and it may be massive, moderate, or small. And there are some special tests to clinically detect it. This is, of course, so big that you don't need any special tests, so obvious. But you need to perform certain tests like shifting dullness. You need to perform fluid thrill, and sometimes it is obvious on the ultrasound alone. So this is ascites. And jaundice, I have already mentioned, this type of jaundice, deep jaundice, would be seen only in extremely advanced terminal cases or in patients with acute on chronic. Chronic liver disease would call very, very mild ictus. There are many other manifestations, like there may be clubbing, there may be Jupiteran contraction, skin atrophy, thinness of hair. So all are manifestation of chronic liver disease. Sarcopenia. Many patients with chronic liver disease, they have wasting of muscles because of sarcopenia. Now, the diagnosis, if it is decompensated chronic liver disease, cirrhosis, the diagnosis is usually very obvious. But of course, the diagnosis has to be supported by laboratory tests. There are two types of tests which we perform. One is laboratory test, the blood test, and the other is imaging. Both are important. Both should be performed in all patients. Number one, to diagnose chronic liver disease, and number two, see the stage of disease, how advanced is the disease, and number three, if there is further complication of chronic liver disease like hepatocellular carcinoma. So in the laboratory test, liver function test, a liver function test, we determine bilirubin, transaminases, ALT, AST, albumin. So these are the tests which are done. Bilirubin is likely to be only minimally elevated. ALT again is not massively increased. ALT may be elevated maybe 2 times, 3 times, but not like you get in acute hepatitis 10 times or 20 times, not like that. So ALT is expected to be elevated, and albumin, I think more important, albumin is likely to be low. Albumin globulin ratio will be disturbed. So this is a liver function test. You cannot, I think my belief is, you cannot rule out cirrhosis if the liver function tests are okay. They simply rule out the decompensated chronic liver disease, but milder degrees you can have perfectly normal looking liver function tests. Then CBC, it's not a specific liver test, but in CBC you are likely to have low HB. There are a number of mechanisms, chronic GI blood loss or anemia of chronic disease. So that may be responsible for low HB, and platelets are reduced. This is very important test. In some cases, we are not sure if this is chronic hepatitis or patient has already developed chronic liver disease. So presence of thrombocytopenia in these patients would indicate that patient has got cirrhosis. In fact, there are some formulae where you use platelet count to determine if the patient has cirrhosis. Then PT or INR. PT is prothrombin time. If somebody's prothrombin level is reduced, patient would have prolonged prothrombin time. Since there are many variables which can affect prothrombin time, and if you can get this international normalized ratio, this is actually derived from prothrombin time. And there are a number of variables which are added to the formula, like a number which comes on that kit and also other factors. So I think you can get INR. You can then easily compare somebody's INR with another person's INR. So PT and INR is likely to be increased, indicating coagulopathy, indicating reduction in prothrombin level. Then some specific tests. Cirrhosis is a end stage of many diseases. Now, if you're interested to know if this is hepatitis C or hepatitis B or alcoholic or other metabolic disorder like hemochromatosis or Wilson disease, then you need to have all those specific tests, and I'm not going to cover them here because this is a general talk on chronic liver disease. On imaging, very important test which I believe should be done on every patient with chronic liver disease is ultrasonography. Advantage is it's a bedside test. It gives you a lot of information. It actually gives you all the abnormalities related with chronic liver disease. Liver texture, normally liver has got smooth texture, but if it is cirrhotic, it can be easily identified by, recognized by a sonologist. The size will be reduced and the liver surface becomes rough and corrugated, and the echogenicity of the liver is increased. There may be dilatation of portal vein. Portal vein is normally less than 1 centimeter. It may be dilated, and spleen may be enlarged, and you can detect presence of ascites in the abdomen. So all those important clinical features of chronic liver disease can be seen on ultrasound also. I think this should be considered the fifth way of examination in cirrhosis. So after inspection, palpation, percussion, auscultation, you should go on to have this ultrasonographic examination to have complete picture. And this is a relatively new test called FibroScan, and this actually determines the amount of fibrosis. If somebody has advanced chronic liver disease, cirrhosis, then perhaps FibroScan might not give us any additional information. But people who have like NASH, non-alcoholic steatohepatitis, and we are not sure how much fibrosis is there already. So this FibroScan may be helpful. In this is ultrasound based or CT based or MRI based. What they do is they produce a certain sound waves which pass through the liver and then come back, and then they determine from the presence of fibrous tissue, from the pattern of these waves, the amount of fibrous tissue present. So F0 would be normal, that means no fibrosis at all, and F4 is full-fledged cirrhosis. Somebody may have any level of fibrosis. I have seen people, and to share with the younger colleagues, I've seen people who apparently do not have any fibrosis clinically, they do not have cirrhosis, but when we do FibroScan, you are surprised to see that it was F2, which is fairly advanced cirrhosis, fibrosis at least. Then biphasic CT may be done in all patients if ultrasound is not clear, but it would be definitely needed in people where you suspect hepatocellular carcinoma. So because that is a complication of chronic liver disease, so there is a blood test which is like alpha fetoprotein, and there is a CT scan biphasic. The philosophy of biphasic CT scan is that hepatocellular carcinoma is fed by arterial blood, not by the portal blood. So using that information, hepatocellular carcinoma will be enhanced during arterial phase and will not be enhanced during venous phase of contrast. So I think that much should be sufficient. But biphasic CT scan is the standard test for hepatocellular carcinoma. Biopsy, theoretically, some people might need, but mostly diagnosis is very, very obvious and complete without biopsy. Some cases biopsy may be needed. Now, the treatment and the prevention, of course, it's a very, very serious disorder, and there are limited treatment options, so our aim should be prevention. First of all, early diagnosis of and treatment of chronic hepatitis C and chronic hepatitis B. Luckily, it is possible. We can make an early diagnosis of hepatitis C, and we can also make an early diagnosis of hepatitis B. We have effective antiviral for both, and all individuals with these infections should be treated so that they do not go on to develop fibrosis and chronic liver disease. Alcohol abstinence. Generally speaking, alcohol is considered to be safe if one stays within a limit, and the limit is for men 2 drinks per day, but not exceeding 5 days a week. For women, it is 1 drink. We of course have other restrictions, social and religious, but when it comes to medical aspect, alcohol, if somebody has already developed liver disease, then absolute abstinence is needed. Otherwise, mild to moderate alcohol consumption is considered safe. Early diagnosis and aggressive treatment of NASH. Most people with truncal obesity and diabetes have this fatty liver, non-alcoholic fatty liver disease. If they have elevation in ALT, significant elevation, 2 times, 3 times, that would be called NASH. I think although this is mostly asymptomatic, but you need to sit down with the patient and explain the consequences of untreated NASH. So I think the best treatment for NASH, in fact the only treatment for NASH which is effective, is weight reduction. One has to reverse the lifestyle which led to weight gain and NASH. So on a long-term period, one has to reduce food intake, fat intake, carbohydrate intake, and total food intake, and has to add some activity. With that only you can hope this NASH will reverse and will not progress. The treatment, unfortunately, once full-fledged cirrhosis develops, there is no effective treatment. There are a number of things we can do. For example, early cirrhosis is at least theoretically irreversible. Once it was thought to be irreversible, but now we know that with effective treatment of chronic hepatitis C and hepatitis B, there may be reversal. But this is usually based on biopsy. So we know that reversal is possible. So I think at least in mild cases, we should aim for this. And then diet and avoidance of potentially harmful drugs, because your diet has got a direct relationship with liver. Somebody with chronic liver disease would probably have reduced appetite, but patients should be instructed to take smaller servings and lesser amount of fats and proteins in moderate quantity. And generally speaking, less spicy foods, and spices should be avoided as much as possible. Avoidance of potentially harmful drugs. Almost every drug is potentially hepatotoxic. Not exactly, but many drugs are potentially hepatotoxic. All those should be avoided, particularly these non-steroidal anti-inflammatory drugs, because these drugs are very commonly used. Many people with chronic liver disease may have an additional indication for the use of non-steroidal anti-inflammatory drug, but they should be avoided because they can precipitate GI bleeding. Similarly, narcotics, a painkiller, they can precipitate hepatic encephalopathy. Paracetamol is itself a hepatotoxic drug, though in small to moderate doses it is safe. So all analgesics should be restricted and should be given only when they are really needed. Palliative treatment of portal hypertension and prevention of GI bleed, and I will have a separate video on this, but we give some medication, maybe beta blocker, maybe nitrates, maybe diuretics, to lower down the portal pressure and prevent GI bleeding. And we also give anti-secretory drug like histamine blocker, H2 blocker, or proton pump inhibitors to reduce acid level, and that will also help reduce incidence of GA bleeding. Then prevention and treatment of hepatic encephalopathy. Those patients who have once encephalopathy, they are likely to develop other episodes, so there will be separate video on this also. But people with hepatic encephalopathy, they should be restricted on protein and they should take smaller amount of protein, because protein is a source of ammonia, but protein is otherwise essential, so we need to give them at least some essential amino acids. Then some antibiotics are used which will lower down the bacterial growth, and they will also reduce incidence of hepatic encephalopathy. Probiotics may also have role, but I think we will discuss this in another video. Liver transplant. Unfortunately, those who have developed full-fledged cirrhosis, decompensated cirrhosis, they have just one option, that is liver transplant. This is now a developed treatment, and I think those who really need it, they should be offered, because this would give them some additional years of life without complication. So this was it. I hope it was useful. I'm Professor Aziz-ur-Rehman from Medurstand. This video was the first introductory video about cirrhosis and chronic liver disease, and I will be talking about ascites and GIT bleeding and hepatic encephalopathy and hepatocellular carcinoma in separate videos. Stay tuned. I really look forward to see you in my next video. Thank you very much. Professor Aziz-ur-Rehman.